Okay, I think it's better for us to start our session because we have dear guests from different parts of the world, and I know that all of them are so busy, so it's better to start on time. That's my pleasure to welcome you all to this session. And this is an international panel that we have as a part of our second Psychiatry Residency Congress in Iran. And uh, that's really my honor to introduce our distinguished speakers to you. We have uh, Haruka from Japan. We have Nika and Clara from Slovenia. We have Zahra from Germany, and also we have Hediye, uh, who is from Iran. Zara told me that she's in specific emergency situations and she wants to start her speech earlier than we planned. So if Haruka lets us, we will give Zara her turn and we will start with Zahra. Okay? Before we start, I just want to focus that our panel will be discussing the psychiatry residency programs across the world, and we have asked our speakers to talk about their psychiatry curriculum, about their programs, about their rotations, maybe some of the opportunities that they have in their psychiatry residency program, and also maybe some of the shortages or any weaknesses that they may have in their psychiatry residency program. So, Zahra, scene is yours, and you can start.
Hello everyone, you hear me?
Yeah.
Yeah, I had like kind of emergency situation right now. A patient of mine just took 20 pills at the same time, and I had to take blood samples, and he has to go probably to another ward. So I just make it quick. Can you share my PowerPoint, or do I have to do it just myself?
Okay, I can do this for you if
You
you
can do
want.
it.
Yeah,
Okay,
of
then
course.
let's.
So
Uh,
let me just,
oh.
you
Mhm.
continue. I will download your PowerPoint.
Yeah, okay. Then I'll just introduce myself. Everybody, my name is Zahra. I'm working currently as a third year resident in Germany. I graduated from Iran, from Shaikh University, and I moved to Germany around 4 years ago. And then 6 months after my arrival, I just began with my residency. So, okay, so I'm using, first of all, I would like to mention something. I am using German on my daily basis, which means that my lack of knowledge, as English knowledge, will probably appear in this session. So if I kind of happen to forget any words, I just say it in Farsi and you help me with that, okay? Mahtab, I cannot see my PowerPoint. Uh, other
Yes,
person, are you
right now
trying to?
I'm opening your file. Yeah.
Okay, I'm working in Potsdam. It's like a small city near Berlin, and my clinic is called Ernst von Bergmann Clinic. So, residency in Germany. As probably many of my colleagues in Iran are interested to continue their studies in Germany. Residency in Germany, like for all of the majors, it's 5 years. In psychiatry, it's 5 years. I mean, on the paper, it's 5 years, but it will probably take longer. Can I myself just move it and scroll down, or do you have to do
Uh,
it?
I should do it for you.
Okay,
So
then
just
can okay, then
tell
can you
me
please?
next slide. Yeah, of course.
Yeah, then can we go to the next one? Yeah, okay. As you can all see, the duration of residency in Germany is like 5 years, which includes 1 year in the neurology and 4 years in the psychiatry. First of all, if you move from the countries out of the EU, European countries, for example, from Iran or from Japan, you have to just get your medical license recognized in Germany, which means you have to just take two specific exams, which I'm not going to talk about because it needs a lot of times, but still, you have to get your medical license recognized, and then afterwards you will get a license called Approbation. And with that Approbation or the medical license, you can apply for residency, psychiatry residency in Germany. And after finishing these 5 years, you will be able to just take another exam, which is called the Facharztprüfung or the specialist exam. At the end, it's kind of ASCII examination, and then you will be recognized as a psychotherapist in Germany. Another thing that I would like to mention is that we have like different kind of rotations, like all other countries in Germany. You have to work at least 1 year with outpatient with outpatients in the clinic, and then the rest you can just do at the ward in the hospital. You also have the option to do child and adolescent residency, psychiatry, geriatric psychiatry for older people, or psychosomatic for 1 year. And it will also count to that psychiatry training. Can you please go to the other slide? Yeah, thank you. Okay. As I told you earlier, it is said that residency in Germany is 5 years, but you probably happen to know some residents that are more than 5 year residents in Germany. And there is a reason why, and I'm going to tell you that. It is because of the curriculum of residency in Germany. You have to first be able to fulfill all the points in that curriculum to get the chance to just take that specialist exam. Without that curriculum, you won't be able to take part in that exam. And the curriculums are in Germany taken very seriously. Just compared to Iran, they are very more seriously taken here. It means that you have to just do, for example, a supervised patient care for like a supervised patient psychotherapy for around 240 hours. And then every 3 sessions, you have to get your session supervised, and you will just have to gather these autographs from the supervisors, and you have to provide them for the specialist exam. Or you have, for example, to do 60 double sessions of case seminars. You have to participate 2 months in a relatives group under the supervisions, or you have to just take part in different kind of seminars around 120 hours, and you have to take part, and you have to show proof that you already took part, so that you will be able to take that specialist exam. That's the reason why most of the residents in Germany don't get the chance to just fulfill their curriculum during 5 years, because it's a lot of work, and they take around 7 up to 10 years to fulfill their residency. But no worries, during your residency, you will get paid. It's something different compared to our country. You will just get paid enough. And there is also one point that I'd like to mention is that your salary during residency and your salary after taking that specialist exam and becoming a board specialist, there is not that much difference. So that's the reason that many of residents prefer to stay resident and work as a resident in hospital rather than being a specialist. And they will get paid enough, and they don't have that Verantwortung. They won't have that responsibility as a specialist. As I told you earlier, my first language here is German. So, okay. And then you have to, as I said, take part, participate in seminars, journal clubs, and etc. Aha. The curriculum in German, also in Iran and probably other countries, is called a logbook. You have to just finish the logbook. But in German, it's called Logbuch. So can you please go to the other slide? Like scroll down. Next one, please. Thank you. So if you like to know more about the logbooks, there is one thing that in Germany is like the United States. Every state has its own rules and probably its own logbook. So if you want to know, there is not that much differences between different logbooks. But if you want to know the exact points that you have to fulfill to be a specialist, you can just Google, as I just put the picture here. You have to just Google Psychiatrie, which is the word for psychiatry in German, and then Logbuch, which is the word translates to logbook, and then the name of state you are applying to. For example, if I'm working in Hamburg, I will just write Psychiatrie Logbuch Hamburg, and then PDF file will appear and you will just see the tasks that you have to fulfill in order to be able to participate in the specialist exam. Next one, please. If you have any questions, I will just answer the questions afterwards. Routine work of residence, yay. I didn't do residency in Iran, but I saw our poor residents there. And that was probably one of the reasons that I decided to migrate to other country. But the residency in Germany is like very different from the one I saw in Iran. And first of all, I will just begin with the shifts, night shifts. As far as I know, in Iran, we had like residents have to do like around 15 shifts per month. In Germany, the maximum shifts that you can do in a month is like 6 shifts. In some branches and some hospitals like mine, the one that I just came to because I recently changed my workplace, is like between 2 to 4 shifts. And we come to work like regularly from 8 a.m. to 4 p.m. And then some days we have like this night shifts, but as I said, it's just 2 to 4, as a 2 do ta chahar, as a not more than that, if any professor is looking right now. And then, but there is a difference. You have to do the shifts all alone. It means that you won't have solid or solace, as it means the resident from first year or second year that will accompany you will be all alone, and they give you a telephone. And then if you have any questions that you probably may, you will just contact your professor directly and then ask your question. Probably at the beginning, it will be very difficult for the starters, and especially for those who came from other countries, to just organize everything, be fast, and then do their works. But as time takes, it will be easier. And the documentation will also be easier. I think I just told you everything, and then you have to also document everything in the electronic health records. Each hospital has its own application, and when you begin in a hospital to work in a hospital, then you have a period of 3 months of observation. Observation doesn't mean that you won't do anything, but it means that in German it's called Einarbeitung. It's called that you will have less work compared to other colleagues, and you will just learn the methods of this hospital. Any questions so far? I guess no. And then the next one, please. Yeah. Do you know the word Bürokratie? It's a German word. It's pronounced as Bürokratie in German, and which means a lot of paperwork. So if you are interested to work in Germany, you have to prepare yourself for Bürokratie. We still use fax. It means that we still fax a lot of things because German hospitals think that emails are not that much protected. Working in Germany sometimes looks like that you are working like in the beginning of the century. They are like they're still using fax. They don't use emails, and you have to just write down everything. There is another problem that I would say, or challenge, in Germany, especially as a foreign resident here, is that the language and cultural barrier. Sometimes there is a fact that no matter how good your German or your English is, it's still not your mother tongue. And there will be still some time that you won't understand your patient, or there are words that you won't understand. There are no translations in your mother tongue for that word, and that makes psychiatry very difficult in Germany, and that's the reason why many foreign doctors don't want to be psychiatrists here. But the demand is very high. I'd say that I lived before in Hamburg, and in Hamburg they live around 20,000 Afghans or Iranians, but there are only 3 psychiatrists, which means that the demand is very high, and the list for the psychiatrists is probably very full. But our colleagues don't want to go to this major because of the language barrier and the difficulties. Yeah, next one, please. Can we go to the next slide? Yeah, I can probably talk till tomorrow on my mother tongue, but if you have any questions, I will be glad to answer them. Night before the due time. Here we always started finishing logbook night before the due time. In Germany, it won't be that easy because at some points, for example, we have like a Selbsterfahrung. That's very interesting also to explain. At one point of this logbook or curriculum, it's called Selbsterfahrung, and which means that you will have a session with another psychiatrist, which is who is an expert, and you will just self-explore yourself and find your weaknesses, and then you will find your weaknesses and you will learn to overcome them in order to be able to be a better psychiatrist. And yeah, any other questions? Thank you for bearing with me and my broken English.
Thank you so much, Zara. No, your English was really good and you talked very fluently, and thank you for your informative speech. I think you covered a lot of parts, and now we have, I think, a somehow clear image of the psychiatry residency in Germany. Thank you so much. And I think we have a lot of things in common. between Iran and Germany, but of course there are some differences. The difference that I noticed is was about the night shifts that you said, that there is no leveling or something like this, and everybody from the start is responsible for everything from the day one.
Yeah, that's
Did
the
I get
problem.
it?
I said, I said that there are two major differences compared to Iran. First of all, like after 3 months of observation, you will just spring in a spring, nee, springen is German. You will jump in a night shift,
Yeah.
and nobody cares if you know enough or not. And you will be left all alone at the emergency room, which means you will have a lot of stress, especially as someone who came from another country, from another health system. But still, I think we will manage it. And then there is another difference. We don't have that hierarchic system here. It means there is no difference between me and the one who is like at the 5th year of residency, or the one who just began his residency. And we will all equal, which is not the same in Iran. And then it means that if, as a 3rd-year resident, I have to do 6 shifts in a month, the other colleague at 1st-year residency has to do the same. And then we will get paid for the shifts. That's the other thing. We will get
a huge difference.
that we will get paid for the shifts, like around 100 to 300 euros. We'll get paid. Yeah.
Thank you so much, Sarah. Thanks for your time. And now we can go to our next speaker, Haruka. We are so excited to learn about Japan.
Hello, everyone. Okay, so let me share my screen first.
Thank you so much.
Okay. Let me try. I want to make it the slideshow. Do you see my PowerPoint in present view or the full screen?
No, I think it's in speaker view. It's not full screen.
Okay, so let me check. Stop sharing first. How can I? Do you know how to? Is it content only?
Yeah. That's
How about
okay
now?
now.
Is it okay?
Yeah.
Okay.
Thank you.
Okay, so hello everyone. My name is Haruka Takusari from Japan. I'm a 3rd-year psychiatry resident in Japan. I'm working at Kanagawa Psychiatric Center in Yokohama. Yokohama is the city next to Tokyo, and which is the most populated city in Japan. So, and first of all, I really appreciate the effort for organizers and participants having this giving me these opportunities in such a difficult time in your countries. So I'm really looking forward today. Thank you. So it's about me. So let me share about myself a little bit. I am Haruka Takusari. I graduated from Chiba Medical School. And in Japan, when all medical students have to do postgraduate clinical training after the graduation. So I did that in Tokyo Metropolitan Hospital. And after that, I think this is a little bit unique from other residents in Japan, but I moved to Thailand to study public health at Mahidol University. And then after that, I came back to Japan and start my psychiatry residency. And from this year, I am also the board member of Japanese Young Psychiatrist Organization, which is short for JIPO. So I'm happy if I have time to share about this JIPO with you all. And so today's menu is first, I'm going to talk about the current status of mental health care in Japan, and then psychiatric training in Japan, and the last, I'll share a little bit my personal thing, like sharing my daily practice. Okay, so let's start with the current status of mental health care in Japan. The reason I want to have this section is because I didn't know much about the situation of the psychiatric medicine in Iran. So I think to know the difference between Japan and Iran, this will make it more easy for us to understand our training environment. So let's look at the geographical data. Japan is a small country compared to Iran, but it's very crowded, like especially like city Tokyo where I live. But also we have some rural areas which is struggling with depopulation. And also the striking difference is the median age, as you can see. The median age of Japan is 49, where the
Dear
median age.
Haruka, sorry
Yes?
to interrupt, but I think there is some problems with your microphone. At first it was clear, but now I think I cannot hear your voice clearly.
Okay. How about now?
No, not yet.
Not good.
In some minutes
How
it
about
gets better.
How about now? Is it okay?
No, it's getting worse.
Not good. Okay.
Okay. Hello.
That's now very good. I can hear you
Is it okay now?
very clearly. Yeah, of course.
Okay, okay. Thanks for letting me know.
Thank you so much.
So, yeah, thank you. So Japan, so as you can see, one of the biggest difference I found is the median age. As you can see, that the median age of Japan is 49 years old, and the aging rate is 29, where the Iran has only 6% of aging rate. So I think the situation of the psychiatry medicine must be different from Iran and Japan. And also, okay, so the next slide. Also, I am looking for some data on the Iranian psychiatry situation, but I couldn't find much. But the number of psychiatrists is obviously very different. Per 100,000 population, we have 12.55, 55, and Iran has only 2.48. And also we have a large number of psychiatry beds per 100,000 population. We have 245, where you have the 12.9. So actually, my hospital is a high volume center. So I think my daily life is a little bit busier than the other residents in other hospitals. But after seeing the difference of this number, I can imagine how you are busy in your country. And also the average length of hospitalization is very long in Japan. And this comes from the historical background in Japan because before and the beginning of the psychiatric medicine, the government wants to seclude all psychiatric patients into some like section or facilities, so that they can isolate them with the other like normal people. And this is done in mainly the private psychiatric hospital, and that is why we have like this more than 80% private psychiatric hospitals. Okay, so now let's move on to the psychiatric training system in Japan. So this is a brief pathways for psychiatrists in Japan. So like I said before, we had the after graduating high school, we can enter the medical school, which takes 6 years. And after that, we all have to do postgraduate clinical training for 2 years before we choose the specialty. And during the postgraduate clinical training, some major department like internal medicine and surgery department and OBGY or pediatrics are one of the obligatory department we all must rotate. And psychiatry is one of these must rotate department. So it means that all medical doctors in Japan have experience somewhat in psychiatry department or with psychiatric patients. And after that, when we join the psychiatric residency program, it usually takes 3 years. And during these 3 years, generally we aim for getting two license. One is a board certified specialist, which is certified by the Japanese Society of Psychiatry and Neurology, and the other is designated psychiatrist. So if it's called shitei in Japan, the difference of between these two are the designated psychiatrist is certified by the government. So it comes above it is the only license which comes above the medical license. The no other department have this license over the medical license because when you get the designated license, you can manage the patient involving the human rights issues like the seclusion or restraint or the involuntary admission. So the government thinks the Japanese JSPN is not the government organization. It is like the academic things. So we all must understand uh, the legislation regarding these human rights issues, and we all have to get this license to conduct this treatment involving the human rights issues. So I am now the third year resident. So I am preparing for both, like I am preparing the report for board certified specialist, and I am preparing the designated and the report or exam for a designated psychiatrist. So sometimes it is tough because we have to write this report in a different like template or the different criteria. So some residents want or pursue only one of them. So during this 3-year residency program, this is a brief description of the program. So when you want to be a certified psychiatrist, you must register. You have to belong to one core hospital, which the core hospital is like the university hospital or public hospital, the high volume center. And also the all core hospital have the affiliated hospital, for example, like private hospital or psychiatric clinic. So during the 3 years, we have to rotate these core hospitals and affiliated hospitals to balance our experience. And all progress managed through online platform. And this is the JSPN web page. And in this web page, I can I can log in my specialist like registration page. And then when you enter, there are a lot of things, but this is one of the table that sorry, it's in Japanese, but they have some list of the disease or the treatment context that you have to experience, and then you have to experience this disorder in this context, like more than 10 cases or like that. So that they want to make sure that the all resident cover wide variety of the disorders or the context. So these are the list of the disorders. So I think the types of disorders um is that is not that special, like schizophrenia, mood disorders, or PTSD, or epilepsy, or like that. And the type of context they want to highlight is that we have to have the experience of emergency cases and seclusion and restraint cases and community care, like the transition to the community, and comorbidity and liaison. So this is my personal opinion. So, but I think that, as you can see, that Japan is the many of the Japanese psychiatric inpatient hospitalized patients are chronic patients. So my hospital is kind of a like acute emergency hospital. So, but like I said, 80% of the psychiatric hospital is private hospital, and they mainly manage the chronic patients. So the residency work at the chronic hospitals have less experience or less exposed to the emergency cases or the community care. So I think this is one of the challenges we have. And also, this is what I feel daily is the quality of the supervision is very depend on the hospital, or even very depend on the senior uh, you meet at a hospital, or you're getting close to. So there is no standard evaluation, or there is no like supervision, how can I say that, the process. So the quality of the maybe the treatment or interview we do is I, there is no like the national standard. I think there is also the guideline, but as you know, the psychiatric treatment is there is a lot of things like have without guidelines or the maybe the standard like interview method. So I think that this at this point, like supervision quality must be improved in Japan. When I talk with some, I feel like that when I talk with some resident in other countries, and also the um, insufficient in we all everything we learn is in Japanese. We all we have everything in Japanese translation. So maybe it is good in some point that it is easy for us to learn that in our own language, but it at the same time it somehow it makes our community, psychiatric community in Japan um, close to international psychiatric situation. So I think we have to, I am also trying to like overcome these obstacles. So this is one of the challenges we have. So from now on, this is my I'd like to share a little bit about my personal life. So this is a Kanagawa Psychiatric Center I worked at, and um, can you see my point now? No, can you see my point? Okay. So this is the main building. Here is the patients come from this route, and this is the outpatient area, and these are the inpatient ward. And also, I think this is unique. Unique thing at our hospital. This is a forensic ward. So forensic ward, which is isolated from the other ward because or buildings, because it needs special security system. And also this is a gymnasium that patient can use to exercise. So this our hospital consists of 9 wards with 6 specialty. So we have, besides emergency ward and chronic care wards, we have adolescent ward and stress care ward and addiction ward and medical observation. It means a forensic ward. So this is a patient's room and day room. This is not the seclusion room, uh, the normal one. But the one interesting thing is that I'm not sure you guys know this one. This is the Japanese style curtain, traditional one. So this is shoji. This is made from paper, Japanese paper. So it can be easily torn, but it is safer for patient because it is not the curtain. It cannot be used as a strings. So as you know, and also it can diffuse the light gently, so it has some effect, relaxing effect on patients. And also this is a day room, and after the COVID-19 we don't allow patients to eat their lunch here, but before they do. And also we sometimes we have some program or exercise program or like some drawing program here. And also because we have the adolescent ward, all adolescent ward have to have the special needs school. So this is one of the example, the special needs school in Japanese psychiatric hospital. And also this is a gymnasium I showed. So my clinical duties is inpatient care, outpatient clinic, night shift, and also paperwork. So I was surprised that have the times of the Iranian residents that do the night shift. So normally I do like 3 or 4 night shift per month. So, but I think it's not it's 3 times is not easy for me. So 15 times I cannot believe that. So I really admire. So, and also we have a lot of paperwork because Japan has a lot of social welfare system, like the pension system for disabled people, or like medical certificate for disabled people that can uh, d- uh, they can compensate their like transport fee. So it is good for patient, but also we have to have a lot of paperwork beside like seeing patients. Now, I have to work until late to complete the paperwork if the patient wants. So, okay. And also beside the clinical duties, I do academic activities for conference presentation, and also the board meeting for Jaipur or CADP. And also in Japan, like I said, there is no standard supervision process during the residency program. So if I want to receive the training for CBT or TFCBT or psychoanalysis, I have to apply on my own and I have to pay on my own. So sometimes I have to do elective training during the weekend. Okay, so this is a Japanese introduction of the Japanese Young Psychiatrist Organization. It is established in 2002, and now it is like non-profit government organization. Uh, and it is established to promote high-quality psychiatric care in Japan and worldwide by supporting the academic development and international exchange of early career psychiatrists in Japan and abroad. Here, early career psychiatrist means until the 10th grade of this psychiatrist or below 40 years old. So I was surprised, like under the 40 years old psychiatrist is considered as early career, but maybe now you can understand because our median age is 49. And also we do some activities like conducting multi-center research, presenting at domestic and international conferences, and managing joint project for early career psychiatrists. And this is one of the highlights event we have every year. This is a course for academic development for psychiatrists, which is called CADP. Do you know Professor Norman Sartorius? He is the former director of WHO's Division Mental Health and also the chief of the World Psychiatric Association. And he has been supported or activities since like 2002, and he comes to Japan every year to give a lecture in the CADP. So it's a great honor for us to have him as a lecturer. And he is very energetic. I think he's almost like 90 years old, but he joined our night party until like midnight after the long flight. So he is very active person. So, and as you can see, we have some international guests here. Last year we have guests from Turkey, South Africa, and Thailand, and Indonesia, like that. So, this is my last slide. I want to welcome you all to 23rd CADP in Japan. It will be held in October 2026 in Hokkaido, Japan. And this time is very special because it is held in conjunction with 11th World Congress Asian Psychiatry. So I'm not sure you know the Hokkaido in Japan. It is the northern part of Japan, and it is very beautiful prefecture with a lot of good nature and good food. So the application is not open yet, but I am vice organizer of this CADP. So if you are interested in, you can contact me directly through this email. So I'm looking forward to seeing you. Thank you so much. So that's all from me today. Thank you.
Thank you so much, Haruka, for your interesting speech. And thank you for your invitation. Last year I came to Japan, and the JSPN Fellowship Award was held in Sapporo. So I visited Hokkaido, and this is really a beautiful state, I can say, and it really impressed me. And during my visit to Japan, what was really surprising for me, which was in your speech too, is this length of stay that you have for your patients. It's really too long, but I think you want to make sure that everything is okay, and then you discharge your patients. Yeah.
Yes, yeah.
Mhm.
But in Japan now, the discharge within 3 months is recommended. But the problem is like that we have the patients who are hospitalized like more than 30 years. So it is very difficult to
Yeah.
try. Yeah, so they have no family, no home like that.
Yeah.
So yeah, that is a problem.
And I have one question. You said that at the first step, you are certified from JSPN, and then you have to get your certification from the Ministry of Health.
Mhm.
Do you mean that when you get certified by JSPN, you're not allowed to work as a psychiatrist? You have to become certified by the ministry or not?
No, actually no. These two licenses are
Uh-huh.
independent.
Uh-huh.
So the certification from JSPN is like certify you are like how can your your professionality.
Competent? Uh-huh.
Yeah, your professionality. And but this designated psychiatry is that you are allowed to do some treatment involving human issues. So you can be psychiatrist without designated
Uh-huh.
psychiatrist or the certification without by JSPN. It is independent. But no,
Oh,
I want to have um, both because yeah, it
in-
certifies
in-
your ability more. Yeah.
Thank you so much. And the thing that you said about that Japanese curtains were really cute. And it's really interesting from your culture that you try to integrate your culture to your practice, which is really cute and very valuable. And that's really kawaii. Thank you so much, Haruka. And I think now we should go to to our next speaker, which is Hediye, who is sitting beside me. And now I will give her my place, and she can start her speech. Okay.
Hi, everybody. I'm Hedia Soleimani, third year psychiatry resident in Rusba Hospital from Iran. To have a quick review about the psychiatry residency program in Iran. First of all, in order to enter the residency program, we have to take an MD degree and then pass an entrance exam, which is annual and integrated. And based on the score we get on the exam and our own preferences, we will get matched to a special field in the hospital we want. For example, psychiatry in Rusba Hospital. The duration of the psychiatry residency program is 4 years here. And in the first year of the program, we have to pass the adult rotations, adult psychiatry rotations. It is contained of 4 trimesters. In the first trimester here, we have the supervision of a senior resident who guides us and learns us the basic routines of the hospital. Of course, we have some theoretical classes which explains us the basics of psychiatry, like disorders like schizophrenia, bipolar, MDD, and like this. After the supervision periods ends, we ourselves are responsible for the admitted patients. Of course, we have the supervision of the professors and educational rounds and morning case reports and things like this. And after that, when the first year finishes and the second year, we have to pass the emergency ward. It's a 3-month rotation, and in that we will learn how to manage the crises, how to triage, and things like this, the emergency part. And then we will have a 3-month rotation of child psychiatry, which is very similar to the adult one. It contains inpatient ward, outpatient clinics, journal clubs, theoretical classes. The tiny difference here is that we have the guide of the fellowships, child and adults and psychiatry fellowships here, beside the professors. And after that, we have a 6-month rotation of psychotherapy, in which we learn different methods there, like CBT, like psychodynamic psychotherapy, like supportive psychotherapy, and psychosexual. There in this rotation, we have our own clients, and we have the supervision of the professors, and we should have some capability to manage these different methods. And in the third year, we have a 3-month rotation in continuum of this 6-month rotation of psychotherapy, which actually completes the things that we have learned there. And the other rotation that we have to pass in the third year would be addiction rotation. It's a 3-month rotation too. And it also consists of inpatient wards, outpatient clinics, and there we learn how to manage substance-induced disorders and by different ways, like pharmacotherapy, motivational interviews, and things like this. And the last rotation in the third year would be psychosomatic rotation, which is a 6-month rotation in Imam Hospital, different from our own hospital, which is a general hospital with different fields. And there we learn how to manage psychiatric disorders in patients with other medical conditions, and how to manage the consultations from other fields. And finally, in the fourth year, we have geriatric rotation, community psychiatry, and forensic rotation, which all have 3 months rotation. And after that, the everything is over. It's finished. About the procedural skills that we have to learn, we have to learn how to perform ECT in the first year. It's mandatory, but learning how to perform RTMS or how to read an EEG, it's something optional, and it's not mandatory in the curriculum. About the evaluation, we have 2 written exams every year. The second one is integrated between all the universities, and if we pass this exam and the other exam, mini-6, we can go to the next level, and that's it. On the end of the fourth year, we have a national board exam too. Let's say that's a hard exam, and if we pass it, we are officially a psychiatrist. Of course, after the research thesis that we have to perform too. After graduation, we have to work about 2 or 4 years in underdeserved areas, and it's mandatory, and we have to do it, and we have no choice about it. That's not good. About the workload and on-call duties, the number of the admitted beds that we are responsible for depends on the rotation that we are in and the number of residents in that grade. Let's say it varies between 6 to 15 patients. That depends, as I said, about the on-call duties and the night shifts. As it was mentioned before here, every level is participated in the shifts in order to divide the workload here. The number of the shifts also depends on the number of the residents in each level, but let's say it's about 5 to 8, I guess. The workload in the shift, it's not that hard, it's manageable, and of course we have educational rounds in order to prepare for the next day morning report, which we have to explain our every decision. That's hard too. And that's it. Here, something that I want to explain about our routines here. In Roosevelt Hospital, in Tuesday, it's something different from the other days of hospital. It's somehow educational day here. We have professionalism sessions, journal club, case reports, and after that, the lecture of professors. That is something interesting, and we residents like it. And the other thing I want to mention is extracurricular activities. Here, beside the curriculum that we have to do when it's obligatory, we have some extracurricular activities that is based on the interest of every resident. For example, we have some literature sessions that we discuss the books that are related to psychiatry, or some poetry sessions. We have this congress that we are now here is based on the inspiration of residents. And for example, we have a group here who produce a psychiatry podcast, and that's the interesting things that we do here. Of course, at the last part, of course, everything is not as perfect and ideal as I explained right now. We have challenges and limitations here. For example, the community-based services have improved a lot in the last years, but still is not as perfect as it can be. Or I don't know about how you know about the situation in my country, but of course the sanctions and the drug shortages and some things like this have an effect on our practice. The things that Zahra mentioned before about the salaries in Germany, which is a good point, is the opposite in Iran. The salaries are not good. It's not enough, actually. But we here are struggling to maintain the standards to the international level, and I think we are doing good. And I hope that in the next years everything would be better here. And that's it. I think that's some photos of our hospital and people in Iran, and I'm really happy for that you listen to me. This is the end. If any question, I'm here to answer. Thanks everybody for your attention.
Thank you so much, Hediye, for explaining our situation in Iran, and thank you for being fair. I know that there are a lot of shortages and challenges that you didn't mention, but you just keep it face saving. Okay, if there is no question from Hediye, we can go to our last speakers, last but not the least, of course, Nika and Clara from Slovenia. We are really, really excited to hear about psychiatry residency programs in Slovenia.
Hello, thank you. Thank you for invitation. I will try to share the screen.
There.
Just a second. To ne vem.
Reloada.
Okay. Anyways, it's been really interesting so far. We're very happy that we're listening to all this information. It differs, the programs differ in very interesting ways, I think. Ne vem, kako naj dam.
Pa sedi sam kamar
Je projekcija.
Sam ne dati predavatelj tako,
Zdaj
kot
to?
je. Ja.
Okay, sorry.
To.
I think I'm sharing the page now. Is this okay?
Yeah, we are now watching this.
Okay, perfect.
You can see the first slide. Okay. Okay. So, greetings from Slovenia. We are two colleagues My name is Nika. This is Clara. We will present together. First, I will speak, and then Clara will continue. Our mentor is Polona Rusprelok, as some of you know, and we work at the University Psychiatric Hospital in Ljubljana. This is the capital of Slovenia. You can see it here on the picture on the right. First, we put some photos about our working days. These are the nice days. Not all of the days look so good, but we wanted to share the sense of community that we have among the residents that we really appreciate. And we think it's very important we can trust each other and discuss some heavy things that we have to do in our jobs. Okay, so about the structure of our training. It lasts for 5 years, so the same as Germany. And our program has recently been a little bit updated, like a small reform. So from July this year, there's been a few changes. I will comment on them a little bit later. Here is the map of Slovenia, and you can see the two big dots are the two university psychiatric clinics. So these are the tertiary referral clinics with more subspecialized departments and more complex patients. One of them is in Ljubljana, in the capital where we are. So we get some more interesting patients, some more interesting treatments. For example, I think it was 1 year ago that we were the first in Slovenia to introduce esketamine treatment for resistant depression. And I think we still only do it in our clinic. Then the 4 little dots are the other 4 psychiatric hospitals, so secondary hospitals. And we can take rounds also in these other hospitals. So we have, we can do most of the rounds in Ljubljana, but not all of them. So we get to know other clinics or hospitals as well. And then there's also many outpatient clinics and mental health centers across Slovenia. So these are part of primary healthcare system. And our government is investing a bit more in the recent years to make this primary healthcare a little bit stronger in mental healthcare. So I think the accessibility is getting better, at least for adults. For children and adolescents, it's also getting better, but the demands are so much higher that it's a bigger problem, I would say, than for the adults. So this is the program. I will just summarize it briefly. So first, when we start our residency, we start the rounds on the emergency and intensive care psychiatry. All of us start here, so this can be a little bit intense at the beginning. And then it usually goes like that we continue to extended care, rehabilitation, gerontopsychiatry, addictions, then outpatient psychiatry, psychotherapeutic wards, psychotherapy, crisis interventions, also developmental psychiatry, where we learn from child and adolescent psychiatrists, which is it's a separate specialty, child and adolescent psychiatry and adult psychiatry in Slovenia. Yeah, so the order can differ a little bit. You can a little bit change your rotations, but more or less it goes in this order. We also do forensic psychiatry, and then also some emergency internal medicine and neurology rounds. So we also refresh and extend our knowledge about somatic illnesses that can also have some psychiatric presentations. Yeah, so a few words about the renewed program. It's changed in a way so that now we have to round a little bit less on the somatic wards, so emergency internal medicine and neurology, and a little bit more at the psychotherapeutic wards, which I think goes with the trend in Slovenia to kind of integrate psychiatry and psychotherapy more. And there's also one extra field that we now run. This is consultative psychiatry and clinical pharmacology. I think probably the biggest change is what you can see at the end, so that the elective program is now much longer. So it used to be 1 month and now it's 8 months. So we can really kind of choose in which direction we want to extend our knowledge. And it's also encouraged to do a part of the elective program abroad, so that we can see some things. Slovenia is a pretty small country, so there are some programs that we don't have. For example, psychosomatic medicine or electroconvulsive therapy. We don't do it in Slovenia, so we have to send our patients abroad to get this treatment, and it's also an opportunity to go and see how they do it. A bit about what we actually do. What's the routine clinical work? It probably doesn't differ that much between countries. We start by shadowing specialists, taking some notes, some discharge letters. They give us some feedback. When we learn more about pharmacotherapy, we can adjust a little bit the medication. Sometimes the specialists then discuss the medication with us, give us some extra literature. It depends on how interested we are, how interested the specialists are, how lucky we are. And then gradually we get more and more individual work at the wards. We start with the emergency rotations on the emergency ward. So when we finish that, this is after approximately 6 months up to 1 year. Then we have to pass the emergency exam. And after we pass this exam, we have to start working at the emergency outpatient clinic, where we actually, I think, similar to Germany, I would say, we see patients on our own. We have the specialist advisor on call, but he's not physically there. So right away, we, with relatively little knowledge or experience, we start working at the most stressful, I think, place in the hospital. So we learned really, really a lot this way, but it can be overwhelming. And then after we do this I don't know, 2 to 3 times a month. And after we do this for half a year, at the emergency outpatient clinic, we start also working night shifts, also 2 to 3 times a month. And in the night shifts, we cover emergency outpatient clinic and also 2 emergency wards. So quite a bit of, I think, a lot of responsibility. Yeah. And the night shift means that we work altogether 36 hours. So in the morning, all day till the next day, and also in the morning. And we are also alone with the specialist on call to help us if it's really needed. Yeah. And yeah, that's it. And after a while, when we feel comfortable, we can also start to have our own patients in the outpatient clinic, depending on the agreement with the employing institution, and the mentor. Clara will continue.
Yes, so my name is Clara. I'm also a resident here in Ljubljana, and now I will, Nika explained a little bit about our day-to-day work routine, and now I will proceed with the academic work. So we have to do regular partial exams in our specialization. Before the program renewal, we had 11 exams divided by themes. Each of us could choose when they completed them, but usually it was after the designated rotation. So the themes you can see here, the list is here. So emergencies, psychiatry, schizophrenia, and other psychotic disorders, addiction disorders, anxiety, stress and neurotic disorders, gerontopsychiatry, child and adolescent psychiatry, sexuality and sexual disorders, mood disorders, personality disorders, eating disorders, and emergency pediatric psychiatry. But now after the program renewal, we have fewer exams, only 5, and they're not divided thematically. But we don't know yet how that's gonna work out because we haven't had a chance to take them yet because the program was renewed a couple of months ago. So we'll see. We also have regular seminars and case presentations, but they're performed among ourselves. So residents do presentations for other residents, but 2 of them are obligatory, and then others depend on the specific rotations we take part in. Our clinic is the university clinic, so they try to include us more and more in research projects, but for now, taking part in research projects is optional. We also, many of us, I think most of our residents are really interested in completing some form of psychotherapy education with personal experience, but getting it right now is only advised, not obligatory. And it can also, it is also a substantial additional cost for us, depending on the type of psychotherapy you wanna get educated into. But just because of that, because of time and cost efficiency, most of our residents choose cognitive behavioral therapy, which is the most, I guess, time and money efficient, and the least is psychoanalysis, which costs quite a lot during the process. I think we calculated once, and with the personal experience, it was more than 10 grand, which a lot of us can't afford during the work hours. Also, we have these obligatory courses of soft skills. They're kind of workshops organized by psychiatrists who work on psychotherapeutic words on different topics. Some of them are are on empathy, therapeutic alliance, therapeutic institutional power. It depends really on each year. And then when we complete the 5 years, we have the final exam to become a specialist. The final exam is divided into the practical part, in which we have a patient and we talk to them, and then we present it to the professors. And then the most important part is the theoretical part with an oral exam. Also, before we can complete the final exam, we have to write a specialist thesis, and we get to choose our own theme. So now I will present a little bit about our opportunities, our challenges, and what we think we miss. First, I will talk about the things that we appreciate, and later I will start talking about the things in which I think, and Nika think, that we lack in. So Slovenia has a lot of unique opportunities because it is such a small country. It only has 2 million of inhabitants. So in Ljubljana, everything is really subspecialized, and a lot of us are here. That's why we, as Nika also already said, really appreciate the sense of community amongst residents, where we gather and we can talk about a lot of things. We have intervisions, even though they're not really in our program. Also, what we appreciate about psychiatry in general is that it's different. It has a different and more holistic approach to patients than in other specialties. We also work really hard towards integrating medical and psychotherapeutic understanding and treatment of patients. We really like to focus on psychodynamic treatments. We also like to cover all of their somatic issues, which our patients have quite a few usually. In the meantime, while they're hospitalized, we get to know quite a lot about the community-based organizations. We get to visit NGO institutions, go on house visits to our patients as a part of the program of extra hospital care, and visit different communities for rehabilitation of our patients. What most of us greatly appreciate is our work-life balance, because compared to other specialties, we have quite a lot of free time. Also, I mentioned we work in Ljubljana, which is the capital, and all the subspecialist areas are here in one place, which makes cooperation easier. Also, kind of all of the residents know each other, and we build a lot of like good energy for working in a sense of community. Also, Slovenia really supports going abroad. It is advised for our residents to pass one part of the residency abroad. You can have it up to the duration of 1 year. The aim is to get to know foreign healthcare and psychiatry systems and bring some of the knowledge, of course, back to Slovenia. We have many ways of arranging this. The most common option and also the easiest is a foreign exchange as a part of European Federation of Psychiatric Trainees program. This is a program that includes a 2-week exchange. It can be done in different cities. It is a well-established procedure. You just kind of have to go online and submit your CV, and then if you are chosen, they do all the paperwork for you, all the organizations. But we can also arrange any exchanges in specialist areas around the world, because we lack quite a lot of treatments like ECT, like Nika mentioned, some prodrome clinics, also psychosomatic medicine. We don't really have a department for that. But the issue is we have to arrange it ourselves on both parts of the exchange contract. So it is hard for us to get opportunities outside of the EFPT program. But the big plus is that currently accommodation and travel is financed by the Medical Chamber of Slovenia. This started happening about a year ago. And now I will talk about some things that we think we miss. I think the biggest thing for us is regular supervision and or intervision. We basically don't have supervisions arranged, and we have no formally arranged intervision, but we sometimes try to manage to do it ourselves in little groups. At the start of the specialization, we get to pick our main mentor, who in theory should provide minimum of 1 hour personal supervision per week and revision of specialization progress at least twice a week. But in reality, this doesn't happen. Usually it's only a role on paper, and we rarely get to see them. We just get to see them when we are actually in their departments. Also, this differs quite a bit, depends on which mentor you choose and how invested they are. Also, we don't have a direct specialist supervision when starting to work on our own. Nika already talked a little bit about that. This is especially prominent in emergency outpatient clinic, where we start working independently. We have a specialist on call, but also because of the clima in the clinic, we are kind of sometimes even afraid to call them and ask, because it's a little bit frowned upon in the clinic. And this is a very stressful project, and in some ways I think it's quite harmful. We think it could be a lot better to observe specialists working in the emergency outpatient clinic first, but we don't get to do that because they don't work on regular days. They just work on the weekends. Then what we miss is also a regular formal teaching program. Mostly our teaching is, it depends on ourselves, of course. It's mostly just seminars that are prepared by residents for the residents, and we have no formal way of specialists like handing their knowledge to us. Also, we think we could use more cooperation with our other clinics and fields, especially psychologists. There are a lot of psychologists working in our clinic, but they have a completely different trajectory of their specialization. They mostly focus on diagnostic process, and we don't have any overlap. Then also the somatic rotations we have now been shrunken on neurology to 3 months and internal medicine to 2 months. And we think it does not provide enough knowledge for later clinical work, because even before, when the programs were a little bit more extensive, we still had issues with that, or young specialists still wonder a lot about somatic medicine and what to actually do. And the last thing we would like is more funding for additional education, especially psychotherapy courses, because we really would like to involve more psychotherapy in our work, but without the courses, because they're very costly, it is a really hard thing to do. Also, we have no funding for congresses. We have to basically pay most of them on our own. We have some money that is provided to us during specialization, but it really is not enough for any additional knowledge. So this is what we, after extensive talks, would come up to, and we are very, very grateful that we can present it here. Till now, it has been very, very enlightening and interesting to listen to other specializations. So I hope you're interested in our specialization too. And we greatly appreciate the opportunity, and we'll discuss it with other residents of how other specializations are also made. Thank you. If you have any questions, just ask.
Thank you so much, Nika and Clara. And that's really kind of you that you will discuss with your colleagues about this session too. And I think what we all have in common is need for more supervision, need for more funding, or I may say, need for more money, maybe in salary or funding for all the mental health budgets that we need in our countries. And we hope for better days to have all this covered. Okay. The thing that you mentioned about your psychiatry program, I think it is somehow similar to some other European countries. You have two pathways for two separate pathways for adult psychiatry and child and adolescent psychiatry. Yeah, did I get
Yes.
it?
There are two specializations. It started it's fairly new. It started a few years ago. So the need for, few years, probably 10.
10, yeah.
So the need for now specialists who work with children and adolescent psychiatry is great, because we don't have that many specialists yet. So the clinics are really, really lacking, and the lines for child to get a psychiatrist are really, really long. This is a health issue right now in Slovenia, but now we are educating other people. Yeah,
it's a little bit different in here, because child and adolescent psychiatry is a subspecialty in here. But that would be a good idea to cover this shortage of child and adolescent psychiatrists in the country. So it was interesting for me. Okay. If there is no question, we can end this session, and I think that was really fruitful, and I myself got a lot of useful information. And maybe we can have a shared photo with each other too. So I asked Hedia to come next to me, and we can have our photo together. And I hope we can meet you again in other sessions. Maybe we can plan for other sessions, or maybe in a more wishful thinking way, we may have some plans or projects together. Okay, so everybody just get ready for the photo, and I will take a screenshot. What should I do? Okay, thank you so much, and thanks for your time and your kindness. Okay.
Thank you so much.
And I should thank all of our audiences that they listen to us. Okay. I think now we can leave the meeting. So bye everyone, and have a good day.
Thank you so much. It was so much fun. It was so fun. Thank you so much. Bye bye.
Thank you so much. Bye bye.
Nice to see you again. Bye.
Bye.
Bye bye.
Ostatnio w Japonii, czyli nam sobie